hate acronyms that people don't define. I think that is just so stinking rude to assume that everybody knows the language you speak. So when you're talking to somebody, your supervising physician, and they use or your clinical preceptor, and they use an acronym you don't understand, don't feel stupid to ask, I'm sorry, what does that mean? Because people use abbreviations that aren't standard. This UDT is undescended testicle. I would never write UDT. I would write undescended testicle because it's not a third. I guess if you're in urology, maybe. But if I'm doing a well child exam, I'm not going to write a UDT. I'm going to write an undescended testicle. The epidemiology, about 4 out of every 100 newborn boys, 75% of those will descend into the scrotum by the time they're 9 months old, okay? After 9 months, it's really unlikely for them to descend on their own. A lot of times, these little babies will have, the testicle will descend, and then it will withdraw, and then it will descend, and they just have a really strong premasteric reflex. So you ask mom, when you put them in the bath water, do you see 2 testicles? Okay, yes you do, great, then I'm not worried about that, that's fine. Physical exam is the most specific test, not necessarily an ultrasound, and certainly you don't want to subject your infant to a MRI or a CT for something as minor as an undescended testicle. Only one normal, because that's the first thing they worry about. You know, we don't have these kids so we can grow old alone. We have these kids so we can have grandkids, right? So the parents are always going to wonder, will this affect their future fertility? And no, all you need is one normal functioning testicle for normal testosterones and near normal fertility. Okay? Undescended testicle is usually can be felt in the inguinal canal. If it's there and it's stuck, sometimes it does need surgical intervention. If it's non-palpable, the normal testicle may lay inside the abdomen, in which case the surgery involves a lapexy. Neonatal torsion, testicular atrophy, the testicle just didn't develop appropriately or properly. And a retractile testicle, that's the one I was just trying to think about. That's the one that just goes up and down, and you just ask the parents when you put them in the bathtub, do you see both testicles? So, okay. No surgery is needed for that. Okay, any questions about undescended testicles? Did you guys cover any of this in urology? Mm-hmm. Okay. Well, I'm just so glad I'm your review before your clinical phase, so let's just keep reviewing. I bet you talked about hydroceles too, didn't you? Alrighty, well, I'll give you my idea of hydroceles. Okay, just fluid in the scrotum or the inguinal canal. You can have communicating hydroceles, you can have non-communicating hydroceles, and you can have inguinal hernias, okay? And inguinal hernia is when you actually, okay, did I ever tell you a story about our cadaver? It was really cool, not on peds at all, but our cadaver had it was like an AC/DC song laying on the table. It was the biggest balls I've ever seen. I know, I'm just going to tell you. So we finally got to the point, and he had, I swear to God, he had his entire large hole. He had so much bowel in his balls. Poor guy. Just anyway, so. Yeah. All right. That's that story. This is how morbid you become as a clinical person. Okay, I'm just going to tell you. So Paul has said he wants to donate his body to science, and I think that's wholly admirable. He realizes that my profession relies on donated bodies to science to educate my future colleagues in this profession. He wants to donate his body to science, and of course, what's the first thing that I think? Oh shit, I'm sending Professor Roark into the anatomy lab next year first. Is that not awful? Is that not morbid? I mean, sorry, I probably shouldn't have shared that wicked little dark side of my brain with you guys, but okay. But no, he really does want to donate, especially if they could do any kind of glioblastoma research. So, all right. All right. Everybody get that? All right. Okay, let's keep going. Here's a picture of different kinds of hydroceles. This first, the one over here is the one over far side is normal, okay, and then it goes all the way over to the complete inguinal hernia, and you can have partial communicating hydroceles, but here's the fun little party trick that I like to teach all my parents when you've got an infant, like a 2-month-old infant with a hydrocele. You know, you open their diaper and you're like, oh, that's you've got such really big testes. And then you transilluminate them, and they glow. Did you guys learn about transillumination? I'm going to talk to Professor. I just really don't like this part. Anyway, you turn off the lights and you say, hey Mom, come here, let me show you a party trick. And you show them, this is great. And you turn off the lights and you grab your otoscope and you do it really quick, because that otoscope, if you don't put a tip on it, it gets hot fast. So you do it really quick and you say, they're like, oh my gosh, that's so cool. And so, most of the time you can see the little glowy testicle in there. But anyway, so I'm going to have to talk to Professor Brooks, because that's one of my favorite jokes. All right. Varicocele. You guys understand a varicocele? You know, I don't think I'm going to finish in 2 minutes, but 3:30 might be a good estimate if you guys keep knowing all of this stuff. But basically, this is a dilation of the pampiniform venous plexus and the internal spermatic vein. Okay, so you got that bag of worms appearance. It's mostly asymptomatic. You find it on a well child exam or by the patient. Usually when they're adolescents, they notice that, you know, their things don't look like everybody else's things. 40% of infertile males are found to have a varicocele, but it does not always cause infertility. So that's kind of one of those chicken or the egg kind of statistics. Is it a coincidence? Does it cause the infertility? I don't know. Most common on the right side, left side due to the blood supply. That sounds like a pathophysiology question, doesn't it? All right. The right inferior vena cava versus the left renal vein. And there's a picture of a varicocele, obviously not in an infant. All right, testicular torsion. You know, by the way, when you're Google imaging for urology, I'm just saying, you know, just be really careful on which links you click on. You might make sure they say something legit, okay, before you click on it. Okay, twisting of testicular torsion, twisting of the testicle resulting in the strangulation of the blood supply. Did you guys deal with this in urology? This is really far more common in the pediatric patient than the adult population. So especially in adolescent males. Severe, sudden, one-sided testicular pain with or without a hydrocele. Personally, I've never seen a hydrocele with a testicular torsion. The bell clapper deformity is a congenital condition where the testes hang in the scrotum and can swing. You know, I mean, anyway, so easy twisting or rotation of the testicles. The gubernaculum. Now, who knows what a gubernaculum is? Okay, somebody explain it to me, Lucy.
So, like, it's some kind of tissue or ligament on the bottom of the testes that keep it from showing.
That's exactly right. I had to Google this. I mean, I had to Google something like gubernaculum. I thought, you know, that's just what, I mean, I call my kids goobers, but I never knew that was a real thing. But anyway, there's a picture of the gubernaculum, just a kind of a drawing of the gubernaculum. There's actually gubernaculum for females too, so but it doesn't take the ovaries the same path as it does the testes. All right, so torsed testes. A torsed appendix testes, a Müllerian duct remnant that is attached to the superior pole of the testicle, and this too can twist upon itself and cause testicular pain. Okay, so that's almost like a torsed epididymis. Does that make sense? Okay, you guys all got that? And there's the gubernaculum again. Okay, testicular torsion. Epidemiology, it's common in neonates and then again in the 12 to 18 years of old. So it's kind of got a bimodal peak in presentation. This is kind of a cute little phrase, time is testicle. 6 hours from the onset of pain to intervention. Okay, so if you go more than 6 hours, you're probably going to lose that testicle. Scrotal ultrasound with Doppler to assess blood flow to the testicle. Do you guys know what you're going to be doing in capstone? You know, we're going to bring in ultrasounds and you're going to learn how to do bedside ultrasonography, which is amazing, amazing. You cannot get an ultrasound. You're doing good. If you call in an ultrasound tech to an ER, you're doing good to get them there in 6 hours, much less get your patient onto surgery if they've got a torged testicle. You will learn how, no, actually you won't learn how to do a torged testicle, because unless somebody really wants to volunteer to be a patient, it's probably not going to happen. But you're going to learn the principles of ultrasound so that you can do that. You want to hear something really cool? Kind of. When I told you guys I took Paul down to Duncan ER. That's where he had his initial head CT after the PCP booked him for a colonoscopy, right? I told you about that. Okay, if you want, I'll share this with you. It'll take a few minutes if you don't mind. Okay, so my husband started, his only deficit was about the 2nd to the 5th of August. He started seeing flashing in his right upper outer visual field. Just a little bit of flashing. He's like, I saw this funny flashing thing today, and I'm like, huh, what were you doing? And he goes, well, you know, I was changing a tire on one of the cash for crappy cars. I'm like, okay, all right. So, you know, it seemed to happen with exertion. I wasn't too worked up about it. But, you know, a week later, now it's nearly constant. It's got a prism, you know. Paul's never worn glasses. Well, he wears glasses. I mean, presbyopia. But he never worn glasses as a kid. All the kids got their poor, you know, horrible, you know, red nose of pigmentosis and horrible vision and astigmatism from me, right? So, and I thought, okay, so I went ahead and called the optometrist, you know, that we all see, got Paul in for an exam. And Paul went by himself, because he's a big boy, and I'm not a helicopter wife. And he went by himself, and he comes home and he says, well, my retina's perfect. I said, wow, okay. And the first thing I'm thinking, it's a brain tumor. You know, I mean, this is so awful. You're just like, oh dear God, why am I such a negative Nelly? But you know, I said it's a brain tumor. So he doesn't have a PCP. 57 years old, doesn't have a PCP, so we decided I'll pick him a guy, get on, I find him, I'm making an appointment for the next week with a PCP, a new PCP, right? Because Paul's really healthy, and he goes into his PCP, and he doesn't want his wife to go, because I'm not a helicopter wife. I said, okay, but this is what you need to tell him. And I prepped him on how to present to the PCP. Don't ask for a head CT specifically, just tell him you've never had vision problems, you're seeing flashing lights, and between the time I booked my appointment and he actually presented, he developed headaches and the sensation of pressure in his temples. Yeah, I know. That's exactly what I thought. So I'm just kind of like, okay, so he comes home from his doctor's appointment, and he says, my blood pressure's fine, because he was thinking, well, I bet my blood pressure's up, this is all just blood pressure related, and I'm thinking, no. And so he comes home, and he goes, yeah, the PCP, he was more interested, okay, Paul felt, when we go to music festivals, we sleep on the van roof, okay? He woke up in the middle of the night, fell off the van roof, impaled his armpit on a folding metal chair. This was 2 years ago at G-Fest in Muskogee, right? So he was more interested, Paul's like, the guy asked, when was your last tetanus? He goes, oh, it was when I impaled my armpit on a chair at G-Fest. And he, like, the preceptor pulls up a chair and sits down and says, okay, I gotta hear that one. And so he tells him the whole story. It's hilarious, you know, and he had a head CT at that time. Anyway, long story short, and then they got to talking, and Paul says, yeah, I'm having these headaches and this flashing light. And the guy's like, yeah, it's probably a detached retina. We'll go ahead and set you up with ophthalmology, but have you had a colonoscopy yet? So my husband goes to this PCP with a brain tumor, and he gets set up for a colonoscopy. So I tell him, I said, well, Paul, it's obvious you have your head up your butt. So anyway, needless to say, I was not happy, Paul was not happy, the headaches were getting worse. So we decided we'd go down to Duncan ER where I work and see Dr. Peterson, because I absolutely adore that man, and I hate going to the ER if I don't go to the doctors. So drive an hour and a half down to Duncan. Worst headache Paul's had so far. We get down there. The reason I started this whole story, Peterson goes and grabs the bedside ultrasound and ultrasounds Paul's eye. No kidding. He puts like, what's that thing they put over the IV? What's that thing called? The what? You know, what's that thing that they put over the IV, the little plastic thing? I can't remember, but it's the plastic thing that they put over the IV to cover the IV site. He has Paul close his eye, puts a little gel on his eyelashes, and then puts the thing on there and ultrasounds Paul's eyeball. And I am absolutely fascinated because he's like, yeah, there's no detached retina here because I just wanted to know that at first. And then he sends him for a CT without contrast, and then it comes back. But I thought that was the coolest thing. He used that bedside ultrasound on my husband's eyeball. So that was really cool. But then he comes back in and says, well, I've got some not so great news. You've got a mass in your occipital lobe, and I can see it, which means it's friggin' huge, because I don't look at these every day. And this was a non-contrast CT, and I can still see it. And anyway, he looks over at Paul, and Paul just bursts out laughing. And Peterson goes, well, I was just terrified that I was going to come down here and somebody was going to say, there's nothing wrong with you. I don't know what's going on. He was really, anyway. All right, so that's our morbid family. And so you will learn how to use a bedside ultrasound, and I might even volunteer to let somebody ultrasound my eyeball just because it was the coolest thing I had ever seen. Okay, so we'll see about that. I don't have eyelashes anyway. When you get to a certain age, you would lose your eyelashes. Okay, so you can ultrasound the testicle too. You want to do an ultrasound with Doppler because you want to see, Doppler, you'll learn about the Doppler. But it's all about, you always think red is artery and blue is vein. Nope, it depends on how you're holding the wand. Red is moving away from the control and blue is moving towards. That's all that is. So, and then treatment, of course, is surgical intervention, detorsion and orchiopexy of both testes. They go ahead and they tack the other testicle so it can't tors, because once you've had one torsed testicle, you've got a high preponderance to the other one torsing. When they get older, they can do, I don't know if they do, if it's an emergent kind of thing, I don't know if they do a prosthetic for a normal testicular appearance, but they can do that. That's an option at some point. All right. So there's a picture of a torsed testicle. It's not real hard to tell which one's the torsed one. Probably the gray one that doesn't have any blood supply to it. Probably. Okay. Phimosis. Physiological phimosis is, any questions about torsed testicle? Okay, all right. Okay, I've told you guys I've worked peds a long time. I get my big words lost, sometimes I get my big words mixed up. So I can always get priapism and phimosis mixed up. So don't do that. Don't be like Professor Labial. Learn the difference. Priapism is Dr. Latassi's lovely orchid picture. Okay, lovely picture. Phimosis is this, okay? Physiological phimosis is the inability to fully retract the foreskin. All uncircumcised males are born with a phimosis. That's normal, okay? It's just an adhesion that happens. Underneath the adhesion is smegma, which is just like, I always wanted to name a dog smegma. But I didn't. We chose Jackson, sorry. Sometimes there can be a skin bridge, between there. But the treatment is diproline cream and manual retraction. No, you just let it happen as it happens, okay? You just let it dehiss as it dehisses, okay? That's probably not the right word. Deadheses as it deadheses. The preventative health benefits of elective circumcision of male newborns outweigh the risks of the procedure, including the risk of urinary tract infections in the first year of life. Okay, so it's really a trendy thing right now not to circumcise your male infants, but ultimately it's kind of a thing. I mean, basically you want your little boys to look like their daddies. So, you know what I mean? So if you choose to circumcise or don't choose to circumcise, circumcision, uncircumcised males are also associated with an increased risk of cervical and genitourinary cancers in women, according to a very well-conducted study in Japan. So just, if your parents ask, just whichever, it doesn't matter. There's care involved with both things, okay? So, any questions about that? But the AAP policy, the American Academy of American Academy of Policies. Pediatrics says that the benefit, the health benefits outweigh the risks. Has anyone seen an infant circumcision? You have? Okay. Did you get to see your own kids? Really? That's pretty cool. A lot of pediatricians. Who over here, what were you doing?
Oh, it was my son.
Your son? What about you?
I was at an internship.
An internship? All right. So, you know, they got this little board that they strap him onto, you know, they, and it's really okay. They give him a little they use a local anesthetic. They give him a little endorphin rush with the dum-dum sucker. Did everybody have a sucker at their circumcision? What'd you guys have?
Sugar water.
Sugar water, okay, sugar water. Anyway, we use dum-dums just because it's easy. You just make sure you don't ever give them a blue dum-dum. You don't want to look like they're perioral cyanosis, because that will freak everybody out. And you know, and it's really a pretty quick procedure. There's two different types. There's oh, now I'm going to talk about it. Of course, I'm going to forget the big words, but they'll be in Dr. Johnson's. But you know, the little ring should fall off. Huh?
The Gomco box?
Gomco, yes. The Gomco is the one where you pull it through, and then Plastibell is the little ring, okay? So, thank you. I really appreciate that. The Gomco, you know, there's quality. I mean, there's a certain amount of finesse with the Gomco. How much foreskin do you pull through? Maybe a little, maybe you give them a half a circumcision, you know. So, I mean, there's a little finesse. But whatever you do, if you decide to have your child circumcised, please allow the provider to use the device with which they are the most comfortable. You don't want them using a Gomco for the first time in 15 years on your kid, right? So, all right. Once the Gomco is the one where they have to put the little, you know, you put a little bit of Vaseline on it or a triple antibiotic ointment on it and cover it with a 4x4 or a little 2x2 or something. And the ring is the one that falls off. If it ever, just warn your parents at their first weight check, if the ring falls down the shaft, bring them right in and let's get it out. I saw a baby at his 2-week visit, the ring had fallen down the shaft. That was not fun, but we actually got it off. I actually used wire cutters to break the plastic, but the baby was fine. Mom was a little freaked out, but the baby was fine. And then sometimes, now these are all phimosis here, okay? And that's normal. You can see the middle picture, he's trying to retract, but it doesn't retract. That's okay. When it's ready, now they still need to they still have to clean, so they retract and they clean around there, the parents do, and then you teach the male children that as they get a little bit older. But sometimes you can have a little chubby baby and who's had a circumcision. I call them their penis likes to play peekaboo in that suprapubic fat pad. Has anybody ever seen a kid like that? Okay, well sometimes when that penis plays peekaboo in that suprapubic fat pad enough, sometimes that skin just gets moist and it can start to grow down again. So every well child check, every time we see a kid, you always just got to double check. If you start to see a phimosis on a kid that's been circumcised, you need to talk to the parents and let them know that you're going to just go ahead and break that adhesion. And then you very quickly, the last thing you do, because this kid will not like you, you just very quickly pull down on the skin of the shaft of the penis and it breaks the adhesion. Doesn't bleed, the kid cries, but he's okay. And then you warn the parents to not let that happen. And the reason I bring that up is because I had a patient that came to me as a 4-year-old, had been circumcised. The parents never, I don't know if the kid's previous PCP ever even looked at the kid's genitals, but he looked just like that. He looked like an uncircumcised kid. I had to send him to urology at 4 years old for another circumcision. So I always tell the parents, you know, please don't let that happen, because unlike these, which will naturally de-adhese, those won't. Okay? All right. A paraphimosis is when you forcibly retract the prepuce behind the sulcus of the glands, and then it kind of gets stuck back there. That's why if they're not circumcised, you don't make a big deal out of it. What I do when I'm doing a well child check for 3, 4, or 5 years old, I say, show me how you pull back your foreskin and clean your penis. and they'll giggle, they'll be embarrassed, but then they'll show me, okay? So you just gotta make sure that somebody's doing something along those lines. But if you can't forcibly retract it, okay? Not with a uncircumcised. I don't know what the emergent basis would be, maybe some kind of an infection or something, but that sounds really yucky and I'd call a urologist. All right, hypospadiasis. This, do you know this one? You guys talked? All right, so that's okay, we'll just go quickly. So basically, you've got an infant, this is rarely picked up on a prenatal ultrasound. Basically, you've got an infant that presents and you're looking at their penis and you're not sure the urethra is right at the tip of the penis. Do not circumcise that child, because if they have to do, you refer them to urology, and usually at about 9 months they'll do the circumcision and they'll do a repair for the hypospadiasm, however you say it, hypospadias. How did they say it in urology? Hypospadias. Okay. I got funky words. All right. So you've got to you care about where it is. Is it in the meatus? Location of the meatus. Is it in the chordae, the dorsal hood? It occurs in approximately 1 in 300 live births, so you're going to see it. It's not that hugely uncommon. There is a genetic component. A lot of times moms don't know that their husband had it and had a surgical repair until their son's born with it. And like I said, don't do the circumcision, and then they'll usually do it around 9 to 12 months old. They straighten, they move the meatus to the tip of the glands, and then they do it. And sometimes they'll use a little testosterone cream. Labial adhesions. Have you guys talked about these? Wow! Did I actually come up with something new, finally? Okay. Sometimes little girls their labias will fuse together. The labia minora will fuse together. So what happens here is there's a couple of different theories. Every pediatrician I've worked with has practiced it this way. If you see a labial adhesion on a little girl, you prescribe Premarin cream, which is an estrogen. Instruct mom to put it on with a Q-tip every night for about 3 weeks, just to explain. You'll do a lot of anatomy lessons with the mom or with the parent, and you'll explain where it is, where's the labial adhesion, where it should be opening, and then they'll put it on with a Q-tip at night, or at the last diaper change before bedtime, and then they come back in 3 weeks and it's usually opened on its own, okay? Some schools of thought say don't treat labial adhesions unless they're causing UTIs or a foul odor or something like that. But my thought is, why not just treat it? If it's extremely thin, sometimes you can use a Q-tip in the office and open it. And I don't know why I'm so willing to break an adhesion on a circumcised penis but not a labia. But that's just the way it is, okay? So you do the Premarin cream, it softens that tissue. You'll get challenged by the pharmacist occasionally. They'll call up and ask why you prescribe Premarin cream for a 15-month-old, but you just explain it's for a labial adhesion, so it's no big deal. Sometimes their insurance won't pay for it on a patient that age. Once it's opened, as long as you warn mom about it, and they've got to do is just make sure the kid sits crisscross applesauce in the bathtub. And once it's opened, it will usually never adhere again. It's more common in chubby little girls, and in parents that are they're not quite getting things clean. Kids that have a lot of diaper rashes because the parents are afraid of being abusive when they're cleaning their child after during a diaper change. This is what I'm talking about. You can see the adhesion goes down. You can kind of see the crack right there. Does that make sense? Can everybody see where that is? I'm sorry, I'm not trying to get too graphic. But you can see where the crack is right there from their gluteus. And so that should all be open right there. And when it's not, it can cause a lot of problems. I check for labial adhesions in all little girls. I had a patient come to me that was 12 years old, and I'm doing her first, no, she wasn't, she was 10. 10 years old. And we thought she had really, no she wasn't, she was like 11 or 12. And I did her well-chopped new patient exam. She's somewhere around there, right on the verge of menstruation, right on the verge of puberty. But she had horrible labial adhesions, so I referred her to a gynecologist. And what she really had was atresia of the vagina. She didn't have a vagina. So they had involved a lot of surgical reconstruction, but someone, that could have been found when she was 6 months old. Heck, that could have been found when she was a newborn. Nobody ever looked. So it's really important, even though it's embarrassing, it's really important to do a thorough physical exam, especially to an older kid that's coming into your practice. Don't assume that just because they're 12, everything must be okay, because they've never been told something isn't okay. All right? Any questions about adhesions, either type? Okay? All right, hydronephrosis, a collection of fluid, a retained fluid, usually urine, obviously, urine, within the kidney's collecting system. Most common congenital condition detected on an antenatal ultrasound. Antenatal is after birth. SFU, the, hang on, I just totally lost that word. What is it? What's that say? Society of Fetal Urology. There you go. SFU grading is 1 to 4. So see, I hate acronyms if you're not going to define them. Society of Fetal Urology. Grading 1 to 4, and there are 4 common causes of it. Uretropelvic junction obstruction. That's the UPJO. Have you guys know all this? You guys did this in kidney or in urology, renal. Okay. And then the uretovesicular junction obstruction and a posterior urethral valve. And then also reflux, and then sometimes it's just a normal variant. Have you seen this slide before? The grading of infant hydronephrosis. Okay. Well, don't label yourselves over it. Just understand that there are 4 grades of it. And grade 4 is the worst. Okay. Here's a bigger picture of the uretropelvis junction obstruction. Obtain a renal ultrasound, so you get the renal ultrasound. The DTPA-NRS is just a fancy type of isotope imaging. Okay, so don't worry about the real word for that. If decrease in renal function, surgical intervention is warranted, which is the fancy word is a pyeloplasty. All right, so that's a grade 4 hydronephrosis. Multicystic kidney disease, multicystic dysplastic kidney. This is a non-functioning kidney. Surgical intervention is only needed if it increases in size or it messes with the patient's blood pressure. Initial evaluation includes a renal ultrasound, a VCUG. You guys know what a VCUG is? Avoiding cystourethrogram. Okay, so they put in a little, they can do it IV. Sometimes they can put in a little catheter tube up into the bladder and put some dye in it and then watch it come out. Or they do dye and watch it come through the kidneys and then out into the bladder and then on out. And then after that you do annual renal ultrasounds until stable, and then only if you get symptomatic. So just because there's a non-functioning kidney does not mean that there needs to be a nephrectomy. Here's the nuclear scan. I said isotope, but yeah, nuclear renal scan. We can see that's the DMSA, and I don't know DT. They're just 2 different isotopes on this nuclear medicine scan. You can see the left UP obstruction. See the way we've got both kidneys lit up and then not so much. The one because it's voided, but the other one contains the isotope. And then a pyelo, there's a picture of a pyelo too. Okay, you can also have VU, vesico-urethral reflux. That's where the flow of the urine goes from the bladder back up into the kidneys through the ureters. to the kidneys. Sometimes they can have an immature one-way valve, okay, the posterior urethral valves. Most common is congenital and occurs during the fetal development. They don't really usually they don't see something this subtle. They won't see something this subtle on a prenatal ultrasound. Now they will be able to identify a horseshoe kidney and things like that, but they're not going to see a reflux on a prenatal ultrasound. A secondary vesico-urethral reflux can arise from high-pressure bladder situations, like maybe you've got a neurogenic bladder or some kind of outlet obstruction, or the kid just doesn't pee all day while they're at school, or they've got some kind of dysfunctional elimination. Affects approximately 1% of healthy children, and usually if you've got one kid with it, you've got a 50% chance of another kid having it. Girls more often than boys, fourfold, which I think is kind of staggering. Standard workup. Okay, baby comes in, first time febrile urinary tract infection is renal ultrasound. If any abnormalities is seen, then you proceed with the VCUG. Okay, so this is the first time febrile UTI. This is not just the first UTI. Most little girls, just from, if you think about anatomy and diapers and stuff like that, most little girls will have a UTI at some point during the potty training years. And part of it is just hygiene. You know, I have spent more time showing little girls how to wipe their booties than you can ever imagine. You know, you wipe from your clean bottom to your dirty bottom, you know, and all of that. So you just got to talk to them about that. Also, sometimes they're afraid to wash that part of their body, and that can lead to UTI. So you teach them to, you know, squat down and wash that part of their body and everything. So, but the first time a little girl gets a UTI and they're potty training, I'm not worried about it. Okay. First time an 8-month-old gets a UTI, I'm a little bit more worried about it. They get a UTI with a fever, I'm going to do this immediately, okay? But potty training, 2.25-year-old comes in, UTI, that's okay. We're not going to worry about it, we're going to treat it. We're going to make them come back 2 weeks after they finish their antibiotics. So they take 10 days worth of antibiotics. We have them come back a week later, catch a urine, make sure it cleared. Okay, if it doesn't clear, then we have another discussion. We send them for further workup. The second time they get a UTI, when they are preschool age, we go ahead and send them for a renal ultrasound and a VCUG, because there's oftentimes they have a little bit of reflux. Okay. Avoiding cystourethrogram requires the catheter in the bladder. More specific for grading the level of VUR, then we don't need the radiation of the nuclear medicine study, okay? The nuclear cystogram requires a catheter, does not give images to grade the VUR, and you use this as a follow-up study. You might use it as a follow-up study. I can't think of when I'd really want to subject a kid to a nuclear medicine study. And here's the different grades. Once again, don't get worked up between the nuances between grade 2 and grade 3, but you should probably understand that grade 1 is the least and grade 5 is the worst. Okay? Here's a VUR. You can see, I think these are just kind of pretty. See the calyx of the kidneys, and then see the ureters going down to the one picture. You can't see the bladder on that picture, and then you see the calyx, and do you see the? Oh, what do we have on that one picture there? What do we have on this picture right there? Yeah, 2 ureters. Yeah, very good, very good. And it looks like it has a little bit of reflux too, so that's pretty significant. All right, so how do we treat it? Sometimes we just do observational. We treat for the dysfunctional elimination habits. Sometimes we put them on some prophylactic antibiotics, Bactrim, and we do yearly voiding studies. Okay, so we just make sure, because sometimes they'll outgrow it, sometimes they won't. deflux injection, you inject a bulking agent into the urethral orifice. 80% work great the first time, greater than 90% after the second injection if needed. So that's a pretty good number, you know, if you do that. A bulking agent into the urethral orifice. And then you open reimplantation. So you reimplant the ureter into the bladder wall to create the 5-to-1 length to diameter ratio. So what does that say? That means you need to make an opening from the ureter in the bladder wall. The opening needs to be as long as the ureter is. You need to do, so like, let's say the ureter is 6 centimeters or 5 centimeters, your opening into the bladder needs to be a centimeter. Does that make sense? The 5-to-1, okay. And that's got a 98% success rate. That's not that typical, by the way. Most of the time, we just follow, we put them on prophylactic antibiotics and just follow them. Of course, I don't work in urology, just general peds, so I'm sure a urologist would say something differently. Urinary tract infections. Any questions about reflux? Great, great. I might be setting a world record for Labial lecture time, just saying. Urinary tract infection, risk factors. Anatomy, female, of course. Their urethral meatus is just down there with all the rest of that dirty junk, okay? Male's risk factor is a foreskin. So a circumcised male has a very, very low risk factor for a UTI. Abnormal bladder or voiding. If you void with really high pressures. So the kid learns that they can bear down and make their pee-pee splash in the potty really loud. Well, guess what? When they bear down and make their pee-pee splash really loud, sometimes it can push the urine back up into the ureters and create a false reflux type situation causing UTIs. Okay? If they don't always pee all the way, if they just pee, I'm playing Barbies, Mom. I don't have time to go pee. So they just go in there and take the pressure off and then go play some more, okay? Or they don't pee at school all day. They wait until they get home. That can have that's a risk factor. Congenital GU tract anomalies, of course, put you at risk for UTIs. Constipation. Let's think about why that puts them at risk for UTIs. Just think about the physiology of the pelvis. There's so much poop down in there that there's no room for the bladder to do its business, right? So that puts them at risk, okay? Or they have a neurogenic bladder where maybe they're physiologically incapable of fully emptying their bladder. If they've had frequent catheterizations or draining tubes, and sometimes, or they've got some kind of a colonization of some type of bacteria. Okay? All right, so the febrile UTI workup, renal ultrasound, VCUG, if there's any abnormalities on the renal ultrasound. A true febrile UTI suspected, recommend a catheterized specimen, okay? So wee bags are great for the first time. Does anybody know where wee bag is? Okay, it's this little thing. It's this little, it kind of looks like, you remember those bags that you could put in the baby bottles for a while that were supposed to keep air out of, you remember those? The Playtex nursery and the baby bag? It kind of looks like that with a little horseshoe of adhesion around it. And you put it around their labia, the anterior portion of their labia, and the trick is to position it in the diaper in such a way so that if they do urinate, it catches it, not just dumps it into the diaper. That really stinks when the MA or the nurse gets it on the wrong way and they peed but it all dumped out. So that's a wee bag. That is the least ideal way of getting a urine in a kid, from a kid, okay? Although that's what a lot of emergency rooms will do, is just a wee bag. Because it's inherently dirty, there's an inherent risk of contamination just from the handling of the wee bag. So if it is a true febrile UTA, you need to do a straight cath for a urine specimen to get that cultured before you start antibiotic therapy. and then you treat it culture specific, of course, you know that. If it's afebrile, you treat it culture specific and conservative dysfunctional elimination program. So you just talk about bladder health and hygiene and proper functioning. UA is kind of a screening thing. Culture, identifications and sensitivities, 100,000 for a clean catch specimen is considered a true UTI, okay? Although my needed to treat thresholds a little lower than that, okay? All right. And once again, we're looking at the renal function. I'm not a big nuclear medicine fan, so just pretend like that slide's not in there. I probably would have taken that out if Dr. Britton had shut up. I mean, I had just been done with our conversation a little sooner. All right, so dysfunctional voiding. What do we mean by the phrase dysfunctional voiding? Urinary incontinence and UTI. They're holding, they're incomplete emptying. This is all stuff I've kind of talked about. They're voiding through their vagina, which means they've kind of got the female version of hypospadiasm. Does that make sense? They've got some dysfunction of the sphincter, or they're having some constipation issues. Urinary incontinence, and we're talking a school-age kid here. We're not talking a 3-year-old or a 4-year-old. So we're going to want to keep avoiding diarrhea. We want to check a UA. We want to do a uroflow, which kind of checks the dynamics of the flow. A post-void residual is where they do an ultrasound to see how much fluid is left in the bladder after they've voided. And you want to just make sure you don't have some type of an ectopic ureter through the ultrasound there too. Treatment, first conservative. Time voiding, double voiding, increased water, voiding posture. You know, you should sit up straight on the potty. Hygiene and address any constipation issues. Okay, medication, cystoscopy, and there's another one of those acronyms. We'll do that. Voiding urethral. Don't worry about that. After failed strict conservation, voiding urethral. I bet that's where they want to do the nuclear medicine study after the failed strict conservation conservative treatment. Okay, nocturnal enuresis, bedwetting. It can be caused by a small bladder, the Itsy Bitsy Bladder Association, IBBA, increased urine production, or a sleep disorder. Maybe they just sleep too stinking heavy to actually be awoke. I remember, okay, I'm just going to be real with you. Last time I wet the bed, I was 4 years old and I dreamed I was sitting on the potty. I still got a spanking. I would not recommend that for my parents today, but that was the way it was in the 60s. So if they just sleep too heavy, they might not realize they need to wake up and pee. Sometimes what you can do for nocturnal enuresis, you can tend to train them. So if you've got a kid that, there's a lot of things you can do. A lot of it is just behavioral, whatever the parents are comfortable with. Put them in their dang Huggies or their, their diapers and just let it go, and don't worry about it till they get to be old enough to worry about it as far as their social life goes, okay? You can also, you put the kid to bed at 8:30. You can restrict fluids all you want, but it's really kind of cruel, but you certainly don't want to give them a big gulp at 8:15. But, let them have a normal amount of fluids, But you can put them to bed at 8:30 before you go to bed at 11:30 or midnight because, you're a working mom and somebody's got to do laundry or do the housework. You get them up and you walk them down the hall to the bathroom and sleepwalk them in there and set them on the potty and get them to pee then. And sometimes you can actually train them to do that, and that works really good. And sometimes you just can't do anything. So you just don't make a big deal out of it. It's not a shameful thing. If it's something they can't control, it's not a shameful thing. We don't shame them. We teach them. I had a bedwetter. You buy those little plastic zippered mattress covers. You lay down an extra flat sheet under their fitted, and you teach them if they wake themselves up because they peed the bed, they put their pillow at the under end of the bed and sleep at that end, or they come and sleep on the floor beside your bed, or they make a pallet on the floor or something, but it's not something to shame a kid over. And you can use the bed alarms, you can spend $1 million on not kids not wetting the bed things, but really most kids will wet the bed until they're around 4 or 5. When it goes past that is when you start thinking about medications like the DDAVP, I'm sorry. That usually starts after 7, and really a lot of pediatricians that I've worked with won't start it until around 10. Okay. In the meantime, during those elementary school years, they want to have a slumber party. You just talk to the mom and say, hey, Sally wets the bed, so she's going to go to the bathroom and put on her pajamas, and then in the morning she's going to take off her diaper. What do they call it? Pull-up. Dang, dude, that would have been a big word I lost. She's going to take off her pull-up and and hide it in your trash can or something. Just warn the parent. Don't make a big deal out of it. All right, Wilms tumor. Have you guys heard of a Wilms tumor? Oh, good, because wait, I saw a no back there, so let me talk a little bit. Malignant renal tumor in young children. The average age is 3 years old. The most common presentation is mom comes into your office and say, I was giving Sally a bath Sunday before, and I just noticed this lump on her back. That is the most common presentation of a Wilms tumor. Presentation: abdominal mass, large, firm, unilateral, high blood pressure, hematuria, abdominal tenderness. You'll find the abdominal tenderness on your physical exam. Your high blood pressure should have been found by your MA, because every child over the age of 2 needs a blood pressure with every visit. Okay, and then the abdominal treatment and the abdominal tenderness. Treatment: nephrectomy, with or without radiation, with or without chemo. That's up to the oncology folks. All right, any questions about Wilms tumor? Notice I did not throw in pathophysiology on Wilms tumor, so you don't need to worry about that. All right, one more picture of my husband, just because I think this t-shirt is fabulous. That was a few days post-op. We were having a really good day.